right, thank you very much. And I'm going to, should consolidation therapy and MRD testing be used for monitoring and treatment? So I'm going to take a slightly different tact than Dr. Lynch took, and that is, I view this really as a question of should you use consolidation and MRD testing to define duration of therapy? Because I think that's an important question that's being asked in the field right now. Should patients get indefinite maintenance, or should we use MRD testing to define who gets consolidation and who continues on maintenance therapy? And the reason I actually think this is really relevant is that in the case that we saw earlier today, both patients that declined maintenance because they were in CR. And I think that that's a mistake. Saying that I've achieved a certain level of response and so I don't need to stay on therapy anymore is missing what you'll see later on. I define the bottom of the iceberg. And I think if we really want to talk about curing myeloma with the detection methods that we have, and I'm going to show you lots of great data that absolutely agrees with what Suzanne showed, but that doesn't mean that it's okay to stop at a certain point. So my question is going to be, does MRD status influence the use of consolidation or duration of therapy? And my answer will be no, it doesn't. You still need to keep going. So I have no disagreement at all with what you saw earlier, that response matters. We have multiple sets of data that suggest that CR predicts for long outcomes. There are young patients, there are older patients, MRD negative patients in CR. All of them suggest that depth of remission does in fact correlate with better progression-free survival and overall survival. All CRs are not necessarily the same. And this is actually data from Antonio Palumbo's trial where patients received either MPR or MEL200. This is the randomized transplant versus no transplant trial. The CR rate between these two arms was identical, and yet the PFS and overall survival continues to favor the group that had a transplant. Why is that? More patients in the transplant group achieved a molecular CR. So molecular CR is able to identify subsets of patients that are going to have better long-term outcome than everybody else. I completely agree with that point. One of the, and this can be done according to molecular. So again, there are multiple different ways to look at this. These are patients from the Italian experience that were MRD negative by PCR. These are patients that are MRD positive by PCR. So I completely agree with this principle. And in fact, we have now evolved to talk about the stringent CR, very nice slides demonstrating the benefit of stringent CR over conventional CR. I think it's not been replicated yet in a randomized phase 3 trial that I know of, but certainly in retrospective data series it suggests that stringent CR is superior to regular CR as we currently measure it. But deciding to stop therapy because you've achieved a certain endpoint, which is what I think the debate was really asking, is like saying, I'm going to stop here because I'm happy. And I think this is the problem. Being here doesn't necessarily mean that you're okay. And even getting to molecular and flow CR is lower on the iceberg. Patients do better if they achieve molecular or flow CRs, but they're still not all the way down here at the bottom, which is ultimately what we're looking for if we're talking about a cure. So simply being satisfied with a conventional CR, a stringent CR, or even a molecular or flow CR, in my mind, doesn't necessarily mean it's okay to say, I'm not going to do consolidation, or I'm okay to say, I'm not going to do continuous maintenance therapy. So why do I say that? Well, this is data, again, on flow from Bruno Paiva in the Spanish myeloma group, and what you'll see is that there really isn't a big difference in a plateau here. Now, this looks like a plateau, but there are only 5 patients out there. Patients are continuing to relapse even if they're in flow cytometric CR. Same, this is overall survival. There is no plateau here saying that because you've achieved a flow negative CR, you can stop therapy. You've achieved the benchmark that correlates 100% with cure. Patients, again, are continuing to relapse with longer follow-up. If you look at other series here, again, these are even the CR patients. So multi-parameter flow is better to be negative than be positive. Still no plateau on that curve. Patients are continuing to relapse. So declaring victory because you've achieved a flow CR doesn't mean you've actually achieved a cure. Patients need to continue to stay on therapy. So depth of response does not tell you it's okay to stop treatment. And I think that that is an important message. The same thing can be said for both older and younger patients. This is overall survival. No plateau, whether you're an older patient in green or a younger patient, an older patient in red or a green patient who's younger. It doesn't mean that just because you've achieved a multi-parameter flow CR that it's okay to stop therapy. Now, what about looking at the UK version? Same data, flow cytometric assessment of CR, no plateau. Patients are continuing to relapse 5, 6, 7 years out, even when they've achieved multi-parameter flow MRD negativity. Now, what about looking at PCR? So this is data from the Italian group looking at PCR instead of flow. They might argue that PCR is a better measure of MRD than flow. Again, continued relapse even with 5 and 6 year follow-up. So just because you're molecularly negative doesn't mean that you're going to do better in terms of cure. We know your remission is going to be longer, no question there. But if the goal is cure, you've not achieved it and you can't just stop therapy because you're in ongoing remission. Again, continued with both the VTD consolidation as well. Now, the newest of the technologies is next-generation sequencing. And ultimately, honestly, I think, and I think Suzanne would probably agree, this is going to be the best methodology we have for assessing MRD. And if you look here again, there's not really a plateau here in terms of time to progression. There's one patient out here who relapsed, and so the curve comes down. So even using next-generation sequencing, which can get you to 10 to the minus 6 in terms of MRD testing, still identifies a group of patients that do better. Being MRD negative is better than being MRD positive, but it doesn't tell you that you can stop therapy because patients are continuing to relapse even in next-generation sequencing MRD negativity. So while it's a victory in the sense that it's improving outcomes to get to these endpoints, it is not yet sufficiently powerful to tell you you can stop therapy. Or, more importantly, that you do or don't need consolidation. Because again, patients are continuing to relapse even further out. Now, what about taking a non-marrow-based methodology to try and tease out who can do well versus who won't do well? This is using PET imaging. So what if you use PET scans and bone imaging to try and identify patients that are at MRD negativity? Again, no plateau on that curve here or here. Patients are continuing to relapse even with PET scans as measuring amount of bone disease that's available over time. So while it is good at telling you better outcome versus worse outcome, it still doesn't tell you it's okay to stop therapy. So despite new methods, whether MRD is assessed by flow, PCR, next-generation sequencing, there is no plateau in the curve. So saying that you're going to use these endpoints to define therapy is not yet ready for prime time. Now the question is, if you don't achieve MRD negativity, should you change therapy? That's not ready for prime time either, because we don't know whether changing treatment can affect the natural history of these curves. But simply being MRD negative by whatever you choose doesn't tell you that you can stop therapy. Same with consolidation. Even in the context of MRD negative disease, it may continue to offer benefit because we can't measure low enough to truly identify patients who are cured. So in my view, you cannot use current methodology to determine the duration or intensity of therapy based on the methodology that we have in 2015. With that, I think I'll stop. Okay?